Yeah, thank you for inviting me to speak. We're going to shift gears a little bit to some of the ischemic conundrums in the cath lab, some issues that I think have become increasingly common with some of the tools that we have now in the cath lab. So this is a case from a few months ago, middle-aged woman with dyspnea on exertion, intermittent chest discomfort, and 2 antinginals. She has chronic atrial fibrillation and anticoagulation with rivaroxaban. She has hypertension, obstructive sleep apnea. Because of her symptoms, she was risk stratified with a myocardial perfusion imaging study that was equivocal with question of either artifact and diaphragmatic attenuation versus possible small to moderate reversible perfusion defect and a normal ejection fraction. So based on her equivocal study and symptoms and 2 antinginals, we proceeded with diagnostic angiography. This is right radial coronary angiography, and you can see here the right coronary artery with a lesion right where that marginal comes off. And this is the left coronary artery system. You can appreciate some diffuse disease in the proximal LAD. There is a middle AD lesion right past that diagonal, and also there appears to be on the right, a little bit foreshortened, but there's some at least intermediate osteoproximal circumflex disease. So based on this anatomy, I guess I'll ask the panel, what should we do? Is it you say 3-vessel disease, think about surgical revascularization, think about single vessel versus multi-vessel PCI, medical therapy, or more testing? We'll be presenting your thoughts.
All right, Sheila, so this is your patient. What do you want to do?
I would perform FFR about at least, I think the LAD is clear. I would perform FFR of the RCA to start. And I think we need maybe I do a steep apicaudal of the circ just to outline that ostium and then make a decision about FFR in the circ.
So clearly some ambiguity in the circ. I'm not sure about the right, but yes, you'd be surprised. And so you really want to know what's physiologically significant yet in this particular case before you relegate somebody to cabbage, not needing it. Dmitriy, what are your thoughts? How would you do this?
Yeah, no, I absolutely agree. I think here, not so much the actual syntax score, but the functional syntax score is what you want to know. So I would definitely interrogate both I would interrogate all of them, the LAD, the RCA, and the osteal circ, and see where the numbers are.
Shami, should we be doing IFR or FFR on these?
Maybe the combination therapy. So let me start one step back, which would be, for patients like this, consider CT FFR so that you can actually avoid an invasive study. So that's a possibility. But if you're on the cath table, I almost always end up using, Manish, both IFR and FFR. And I think I would remind everybody, 0.81 FFR versus 0.79 FFR, even though the data was on that 0.8 cut point, it's never that dichotomous. And the reason I like to get both IFR and FFR is I like consistency of data. And so if you have a questionable story, moderate lesions, moderate result on your equivocal result on one of those two, then I really need more information. But if they're all consistent in a single direction, that just gives you more validity. So I generally do both, IFR and FFR, in this day and age.
So right. Yep, so that's exactly what we were thinking. We said equivocal, non-invasive study, we need more testing. So we proceeded with IFR, and as Dr. Feldman said, we did IFR of the 3 vessels. This is, again, atrial fibrillation. You can see the irregular R to R. It takes 5 beats with IFR, and you can see an IFR of the right of 0.97, IFR 1.0 in the circ, and an IFR in the LAD that was repeated a couple times, which was 0.94 and 0.93 being the lowest value. So the question is, again, what do we do? Are we done? Send the patient home, medical therapy, borderline LAD IFR with equivocal study, and as Dr. Mahmud was saying, do more testing, do of FFR, or just stop debating, let's fix the one that looks the worst and that also had that equivocal anterior ischemia. Any thoughts?
Can I ask a question to the panel? Like, if we have an MPI that's suggesting ischemia pre-cath, do we need to do another physiology study during the angiogram?
So, again, I think if there's concern about discordance or if there's some thought about unreliability, then yes, I would not have IFR'd the LAD at all. And if I was going to do the LAD and if it was equivocal, I would have done FFR. What I really wanted to know was the circ. So the only thing I was going to do is the circ. I don't have the patience to IFR all three vessels, frankly. Now, having said that, I am exceptionally uncomfortable with a lot of the non-invasive nuclear testing that we get. So this is an adjunct. So I would have treated the LAD, or if I got this, FFR the LAD.
Yeah, and I think that, go ahead.
I was just going to add patient history and optimal medical therapy prior to the cath lab is a critical aspect of this. If you've got somebody who's clearly symptomatic on good medical therapy with anterior ischemia, then maybe the other lesions you can interrogate just to make a decision of multi-vessel revascularization versus what you think is the culprit. And this 0.93, if somebody's symptomatic on 3 antianginals, means very differently to me than someone who has that questionable chest pain and is on no drugs or on 1 antianginal.
When I found myself in this situation with the IFR being positive, when you have the ischemia on the nuke and the lesion looking like this, and the patient's symptomatic on the table, I have converted to FFR, and then I've done it just like in the trials, good technique, giving nitro before and watching and comparing them, and that's helped.
Yeah, I think those are all good points. And just to clarify again, this is a patient that does not have definite anginal symptoms, has some shortness of breath. This is equivocal study, and I should have added the images, but it was truly equivocal, so that's the reason we did the full coronary physiology. And again, at this point, we said, let's get more information. So we went ahead and we did an FFR of the LAD, dropped a little bit the blood pressure. You can see the irregular rhythm in the context of the atrial fibrillation, gave some nitro, disengaged the guide, got rid of contrast on the guide as well, removed the introducer, and this is an FFR of 0.75. So I think it becomes a little bit more clear.
So did you do the CFR as well?
Great question. We did not. So so now the question is what to fix, right? So we have the discordance IFR LAD 0.93 and the IV adenosine FFR of 0.75, and clearly this looks like the worst lesion, but there's some proximal disease. So after a pullback, the clear step up, at least with the IFR, was at this particular spot. So we went ahead, took care of that. We placed a 2.75 by 16 millimeter drug-eluting stent, had a nice result. So now the question is, are we done? Let's go home. I don't like the proximal disease, pass me another stent, or let's do a quick post-PCI FFR. Any thoughts from the panel?
Yeah, this calls for more FFR. Now that you've relieved the distal lesion, you have more blood flow going down the artery, and so there are cases where you don't have a positive FFR proximally.
Yep. So that's exactly what we did. We did a post-PCI adenosine FFR, it's 0.73. So we went ahead and we placed a 3.0 by 32 drug-eluting stent. And after that, this is our final result, and that showed a final FFR of 0.85. It was post-dilated, and it got a couple of stents. So why am I showing this case? There are 3 lessons from this case. One, it's what is the data of IFR and FFR in patients with atrial fibrillation? 2, this was a revelation. What about nadir FFR versus average FFR? And 3, how to address these issues of IFR versus FFR discordance that may happen more commonly if we do both tests. I just have one quick slide on each issue. There's really not much published data on neither IFR or FFR with atrial fibrillation. There's actually this interview with Justin Davis, one of the investigators from the IFR studies, that he actually, in the New England Journal of Medicine, gets asked what's the reliability of IFR when you have irregular ROR intervals and identifying the diastolic phase. And he shows this example and essentially says that the algorithm, it's able to identify the diastolic phase reliably, and that this studies included all comers so that we can use such data reliably. Not much published that I could find on FFR. 2, and we have Dr. Seto sitting here in the front, it's this issue of either nadir versus average FFR and beat-to-beat variation. So after I went back and interrogated this waveform, you can see that the software, this is the Volcano software, and this happens with more commercial FFR softwares. It's actually a chapter from Dr. Kern and Dr. Seto. You can see here that our value and all information was on this nadir FFR with a value of 0.75. However, as you can see in the context of atrial fibrillation and beat to beat variation, you can really get FFRs all over the place. So as this, there's some discordance in the literature about this. Some people talk about single beat nadir FFR, but this is Dr. Cito and other investigators have argued in this chapter, there's a value for doing average 3-beat FFR, which actually you can just change very easily on the software. Had we done that, which we didn't do in this case, if you get a 3-beat average FFR, you can see it's a value of 0.82. And it very well brings the question, would you have done just medical therapy alone? Put that now into the context of the data of addressing IFR and FFR discordance. So this is a paper for Chris Cook in JACC Interventions just a few months ago. This is from the UK, in which they did IFR, FFR, and CFR in a number of cases. And when you look at patients that have non-obstructive coronary lesions or negative IFR and FFR, CFR, it's higher, and the discordant values, such as in our case, negative IFR with positive FFR, has a very similar pattern as those patients that have no significant disease that are non-obstructed, whereas those that have significant lesions with significant FFR and IFR behaves more as those when IFR is positive. So this data would have suggested that had we believed the IFR, we would have potentially not stented anything and done medical therapy, which is actually very thought-provoking. Overall, the patient did well, symptoms resolved. She remained asymptomatic on follow-up and was maintaining anticoagulation, antifibrillation, and thienopyridine without aspirin. But I think this brings to questions a lot of lessons about these issues of IFR and FFR. Thanks.
I think, Shami, your point is very well taken. I mean, with this case, is taking AFib out of the equation, you know, with borderline numbers, and when you're struggling positive FFR, negative IFR, or the other way around, I mean, you have to go back and say, you know, what is the patient here for? And are the symptoms real? Do you believe the symptoms? And that's really, you know, the crux of the question.
Did you do aspirin for 3 months?
No aspirin, just novel oral anticoagulant and the thienopyridine. No aspirin.
Yeah, and like you said, we're even taking AFib out of the equation. When you throw that into the equation, you have questionable data, plus now you have triple therapy to contend with. And so I do think at the end of the day, this reminds all of us, when you get on the cath table, just make sure those, and this goes to the AUC as well, a lot more attention is being paid to that for good reason. It's to make sure that when they're on the table, we're intervening for the right reasons. We're not intervening because the FFR is 0.79 and we're not sure what those symptoms are. So that, I think, is probably the takeaway. And conversely, we're not letting them off at 0.81 when they're having recurrent episodes of what are classic angina and an abnormal stress test.